Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm delighted to welcome you to a new year and to the multimedia summary for the journal's January 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article which examined the impact of health literacy on hospitalizations and mortality in patients with heart failure. It is authored by Dr. Matteo Fabri and colleagues from the Department of Health Sciences Research and the Division of Cardiovascular Diseases, Mayo Clinic, Rochester, Minnesota, the Division of Geriatric Medicine at Johns Hopkins University in Baltimore, Maryland, and Olmsted County Public Health Services, also in Rochester, Minnesota. Using the medical records linkage system of the Rochester Epidemiology Project and a composite score from established screening questions and 3 5-point scales to assess health literacy, the authors prospectively surveyed residents living in an 11-county region in southeast Minnesota. Questions in the survey included: how confident are you filling out forms by yourself? How often do you have someone, such as a family member, a friend, a hospital or clinic worker, help you read hospital materials? And how often do you have problems learning about your medical condition because of difficulty reading hospital materials? Of approximately 5,900 patients identified with heart failure, some 2,600 eligible patients returned a survey. Of those, approximately 11% of the patients had low health literacy, with the range among the 11 counties being 7 to 17%. These patients, on average, were older, less likely to be married, and had lower educational completion than those with adequate health literacy. Patients with low health literacy had a higher Charleston comorbidity index and a higher proportion of peripheral vascular disease and cerebrovascular disease, renal disease, and diabetes. The authors also found that poor health literacy was associated with more than a 2-fold increased risk of death compared to patients who had adequate health literacy. Based on these results, the authors suggest that this simple, efficient, and reliable screener should be implemented in clinical practice to identify those patients with heart failure who are at a higher risk for poor outcomes and to design interventions to support the informational and self-care needs in this patient population. This article is accompanied by an editorial by Dr. Hector Ventura from the John Ochsner Heart and Vascular Institute, New Orleans, Louisiana, and by Dr. Liana Piena from Albert Einstein College of Medicine in the Bronx, New York. Dr. Ventura and Dr. Piena discuss and underscore the importance of the findings of Fabri and colleagues, and that integrating strategies which include health literacy may reduce rehospitalization and improve outcomes in patients with heart failure. They also note that rates of health literacy may vary in such studies. For example, a prior study of 600 patients with heart failure by Drs. Macabasco, O'Connell, and colleagues demonstrated that low health literacy in 37% of the study population, in contrast with low health literacy in 11% of the patients studied by Fabri and colleagues while using the same questionnaire. Although the reasons are unclear, this may reflect the specific community cohort. Olmsted County has a high level of literacy, and this county contributed most patients in the study by Fabri and colleagues. Our first highlight article is an original article in which the authors examine the degree of consistency in evaluations by patient and physician regarding the benefit of an orthopedic procedure. Such an analysis is particularly relevant as the current healthcare environment increasingly emphasizes value-based care rather than fee-for-service, and in which the patient is viewed as a consumer. The perceived success of a given treatment will depend upon the overall perceptions of the patient in this regard. Dr. Dave Shukla and colleagues from the Department of Orthopedic Surgery at Mayo Clinic in Rochester, Minnesota, compared whether the Summary Outcome Determination Score, a scoring system devised by the senior author of this paper, Dr. Sean O'Driscoll, exhibited a high level of physician-patient agreement in surgical patients. as there is an often observed disparity between patients' evaluations and physicians' evaluations of the relative benefit derived from surgical procedures, this article addresses a timely issue. Data were collected postoperatively by both the patient and the physician in 164 patients who underwent surgery for elbow and shoulder injuries at Mayo Clinic between December 2005 and December 2015. The summary outcome determination score is made up of a specific descriptive category and a specific number. The various categories reflect the relative benefit or lack thereof of the procedure. The number on a scale ranging between +10 and -10 also reflects relative benefit or lack thereof of the procedure. The criteria for agreement include the physician and the patient assigned the same category and same number. The same number was assigned but the category differed by one level. Or the same category was assigned but the number differed by one level. When taken together, 161 of 164 patients, namely 98%, rated the same outcomes of surgery at the same categorical level or numerical level or both. The authors thus conclude that based on the summary outcome determination score, there was a high degree of consistency between the patient's and the physician's assessment of how the surgical treatment affected the quality of life of the patient. The authors also suggest that given the brevity, the ready applicability, and the high inter-rater reliability of the summary outcome determination score, this scoring system may be useful in other subspecialties and specialties to assess outcomes. The second highlight article is a consensus recommendation that summarizes the evidence in support of the use of opioids in patients with refractory restless leg syndrome, and which also outlines an approach to opioid use in clinical practice. It is authored by Dr. Michael Silber from Mayo Clinic in Rochester, Minnesota, and colleagues from several leading medical institutions on behalf of the Scientific and Medical Advisory Board of the Restless Legs Syndrome Foundation. The restless leg syndrome is a common disorder in which 2% of the population may have substantial symptoms at least twice per week. Patients usually obtain initial relief with first-line agents such as dopamine agonists. However, as many as 50 to 70% of patients using dopamine agonists develop drug-induced augmentation characterized by earlier symptom onset, involvement of arms and trunk, and shorter duration of relief from treatment. The growing epidemic of opioid abuse has made many caregivers hesitant to prescribe opioids. However, published clinical trials and case series demonstrate considerable effectiveness of opioids in treating refractory restless leg syndrome, a distinct disorder with a different etiology, pathophysiology, and epidemiology from chronic pain syndromes. The authors use a case history to demonstrate a typical example of treatment augmentation and discuss preclinical and clinical studies of opioid pathophysiology, as well as the indications for using opioids in the restless leg syndrome. A number of opioid medications in low dose appear effective in refractory restless leg syndrome. The authors provide detailed considerations regarding such use of opioids for refractory restless leg syndrome, emphasizing, among other considerations, the need to fully explore alternative and first-line agents before the use of opioids, attention to other conditions that may cause refractoriness to therapy, informing the patient of the expectations of treatment, establishing an opioid contract with the patient, and initiating therapy with low opioid doses. As long as these and other considerations and precautions, as detailed in this consensus recommendations, are appropriately met, the authors recommend that opioids can be used in selected patients with refractory restless leg syndrome with a beneficial effect and a favorable risk-benefit ratio. The third highlight is a review article that summarizes current knowledge about long-term cognitive impairment, which is common in survivors of critical illness. It is authored by Dr. Amra Sakusic from the University of Tuzla in Bosnia and Herzegovina and Mayo Clinic in Rochester, Minnesota, and colleagues from several national and international medical institutions. The incidence of cognitive decline after critical illness may be highly variable, ranging from 4% to 64% across different studies. The authors sought to summarize current knowledge regarding potentially modifiable risk factors during intensive care unit treatment that may influence the development of this condition. In this systematic review, the authors identified more than 3,000 studies, with 28 studies meeting the inclusion criteria. In evaluating factors that may influence long-term cognitive impairment, the authors assessed the effects and duration of mechanical ventilation, the use of sedative or analgesic medications, in-hospital acute stress symptoms, blood product transfusion, blood loss, hematocrit levels, glycemic control, hypoxia, and the length of intensive care unit stay. Their review showed that delirium, particularly when prolonged, is a central, potentially modifiable risk factor associated with an increased likelihood of persistent cognitive impairment after intensive care unit hospitalization. Weaker associations were observed with glycemic control and in-hospital stress symptoms. Most studies did not find significant associations with the other listed factors, including mechanical ventilation. As always, you can access these highlights and editor's choice articles free of charge during the entire month of January. If you visit our Mayo Clinic Proceeding websites at www.mayoclinicproceedings.org, you will find other free content such as our Path to Patient image quiz, Art at Mayo Clinic, stamped vignettes on medical science, and interesting medical images. Mayo Clinic Proceedings also offers access to our social media, which you can access by clicking the buttons on the top of the home page to follow us on Facebook, Twitter, and YouTube. Our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. You can also check out our YouTube channel, where you'll find videos of full author interviews, our 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which is available from our website on the home page as well as through iTunes. And, as always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.